in. Welcome to the Nutrition, Health, and Wellness series here at In the Rooms. I'm Lulu Cook. I'm the author of the Complete Anti-Inflammatory Book for Beginners. I'm a dietitian in multiple countries, and I'm a counselor. So I'm here, and I'm in recovery, and so excited to be here with you, offering some actionable information and strategies to support mental health, physical health, and a happy, healthy, high-energy life in recovery. We've got people here with all kinds of recovery stories, and that's a beautiful thing about In the Rooms. On the technical side, we're trying something a little bit different today. I'm going to share the information around our topic today and then take questions at the end so that we get a real clean recording just on me sharing that I can make available later if you wanted to go back and review the information or what have you. Anonymity will be protected that way, and so we'll try that. I'm going to give the information first before opening it up for people to raise their hands and ask questions or share their experience. You can, however, use that chat box as we go along. If you have questions that arise, I'll try to keep an eye on that chat box in the bottom right corner. And as I said, the recordings will be available later. I'll post those on my Facebook site and YouTube. The Facebook is Gut Feeling Nutrition Therapy at Facebook. And you can also always email me and request the slides that these presentations come off of if you'd like notes, essentially. Those slides also have a wealth of references to the scientific studies that I'm referring to and leaning on to be able to offer you really evidence-based information to figure out how these topics pertain to you. So this is a great place to start with our topic today. How does it pertain to me? And the topic in general is weight loss surgery. So some of us might think that's not my story. It doesn't impact me. But what I think you'll find is as we get into it and we start to unpack the connections between weight loss surgery, different kinds of binge eating or overeating that can get us to unhealthy weights, escalating risk of alcoholism or addiction for people who are post-surgery, people who have had weight loss surgery. These are all deeply, deeply intertwined. And I think for many of us, that idea that, it's not my problem, I'm here for something else, we might find as we listen in to these connections that it's a not yet for us. And of course, for others of us, we do have that experience of having had compulsive overeating or weight loss surgery. We've experienced directly how that impacts with substance addiction. So we'll get into a lot of that today. This is really general information in these classes, and so if you have really specific concerns or questions that pertain to you, welcome to email me, Lulu at gutfeelingcoaching.com. Welcome to email me with your particular personal concerns. We'll pick up a little bit today on the topic from last week, which is what about weight? How do we deal with that question of finding a happy, healthy weight range in recovery? And then from that, we'll dip back in, touch on weight loss medications because we just flew past that last week. And then we'll get into weight loss surgery and how that interacts in a lot of different directions with drug and alcohol recovery and recovery from binge eating disorder or other eating disorders. Note on language, I refer to people with obesity or overweight, or I refer to obese people and overweight people. people of larger bodies. Sometimes I'll say fat people or someone who's really fat, and that's in deference to people who identify in that community who have shared with me that might be a, offered with respect, said with respect, we could destigmatize the idea that there's something wrong with being a person in a bigger body. And today we'll also be talking about bariatric surgery. So for those of you who are not familiar, bariatric surgery is just another way of saying weight loss surgery in regards to those kinds of stomach stapling or gastric banding, those kinds of procedures. We'll refer to them today as both weight loss surgery and bariatric surgery. So, onward. Dipping back into that pressing question, do diets work? I established last week there is a really wide range of, quote, healthy weights for most people to be at. And for most people, there are weights at the far extreme of very, very low weight and very, very high weight that are going to have a negative effect on our health and our energy and our well-being. For those who choose to use dietary approaches to try to stay in that healthy weight range, all reasonable, balanced diets look the same over time. So you can find the one that works best for you, diets that are based on a balanced set of macronutrients, a balance of protein and fat and fiber. You can play with the balance a little bit, pro and con. You could be paleo, you could be vegan, you could be Mediterranean, you could be keto. They all work if they work for you and are, well planned and thoughtfully done to be able to meet nutritional needs appropriately. So there's no one right diet, and in all, when we look at all of these different kinds of diets over time, 6 months out, 12 months out is how those longer term studies often go. We'll see that most of them, at best, you're going to get about 2.5 kilos of weight loss at 12 to 18 months. So that's 6-ish pounds, 7 pounds. So really, at best, all of these dietary interventions, the average is going to be maybe generously between 5 and 10 pounds of weight loss a year or a year and a half or 2 years out. We all know the magical stories of someone who's lost 30 pounds on a diet and kept it off and they're doing great. And that is possible, that is out there, but that won't be many of our experience. So just having a little bit of a reality check on that. They do work a little bit, those healthy diets. So sometimes people might turn to weight loss medications then for that little extra bit of support. The diets are doing some of the work, but we need a little bit of extra support to try to reach those weight ranges we feel good in. And most of the approved weight loss drugs work. I mean, if they get approved, part of the reason why is because they work. So that would be approved by the Food and Drug Administration and other similar organizations in other countries. They typically would result in about a 5% weight loss at 1 year. That's according to a review of 28 randomized controlled trials. That's a pretty high level of evidence, very carefully designed studies. So looking at 28 of those, thousands and thousands of people trying these major weight loss drugs, and we see that they would all have about a 5% weight loss at 1 year. We've got any of them from Orlistat, which has very low side effects. It's also the least effective. We see liraglutide, which can help lower blood sugar. So for people with more of a diabetes or pre-diabetes challenge, that might be a good option. Lorcaserin is low efficacy. It interacts with alcohol in terms of alcohol consumption, and lorcaserin together increase the effect of the alcohol, and that one actually has been pulled from the market, at least in the States, as far as I know of right now. Another big one would be the naltrexone bupropion combination drug. And this is one I like to really highlight for people in recovery, because many of us might try either naltrexone or bupropion for managing addiction symptoms. The naltrexone is an opioid antagonist, and so it's used in part of the medical treatment for both alcohol addiction and heroin or opiate addiction. Bupropion, sometimes known by the brand name Wellbutrin, this is used for smoking addiction. It's also used as an antidepressant. So these are drugs that, medications that are familiar to some people in recovery circles. But from a weight loss perspective, they take the two of them, put them together into this combo drug, and then there's a place to be really cautious if you are in recovery, because that combo drug, the naltrexone bupropion, can lead to neuropsychiatric complications in people who have that history of chronic alcohol or opiate dependence. So if you've got that background, alcoholism or heroin addiction, for instance, this would not probably be the right drug for you. You'd want to really check in with your healthcare provider on that, because you'd have a higher risk of having some kind of psychiatric side effects that most of us don't want. So that was the brief flyby on weight loss medications and how they might both support some weight loss, if that's our interest, but also how they could impact with recovery. So moving on now to bariatric surgery or weight loss surgery. In 2009, there were 220,000 bariatric surgeries performed in the United States alone. It's really recognized as the most effective treatment for severe obesity. And of these different types of procedures, and I'll just outline them real quick in a minute, but the bottom line, the principle is they all somehow decrease the size of the stomach, less food can then be consumed, and weight loss occurs simply from the consumption of lower amounts of food. It can also occur because there's a 72% reduced fat absorption. The digestive tract does not absorb as much fat. And also a 25% lower protein absorption happens. So you're consuming less food and you're actually getting less food out of it. You're getting less energy, less calories out of the food you're consuming. So right there, that leads to weight loss for most people. There's also an impact from these surgeries on the hormones that are typically managing our satiety levels. That's how full we feel or how hungry we feel. So hormones like gastrin, ghrelin, peptide YY, even dopamine. Dopamine becomes dysregulated in some of these surgeries. Dopamine is tightly linked with driving addiction pathways in the brain, because it's the hormone that sort of double clicks when the brain thinks it's got something good, something that makes it feel good. It's not that the dopamine is actually making us feel good. What the dopamine is doing is it's double clicking on, that was good stuff, we should go get more of it. We should feel motivated to go get more of that, because when we get that stuff, whether it's a food or a substance or an activity, when we get it, we're gonna feel better. So the dopamine is like a driver or a reinforcer for that, and it becomes dysregulated with some of these weight loss surgeries. Now, on the beneficial side, besides the fact that these bariatric surgeries are some of the most effective ways to lose significant amounts of weight, they can reduce hypertension, reduce hypercholesterol, reduce or even lead to remission of type 2 diabetes. Sleep apnea improves. And gosh, people's quality of life can just blossom for people who have really struggled with carrying much bigger bodies than feels comfortable for them. Being able to pull some of that weight off can lead to just a much higher quality of life in many regards. So it's got massive effects on every level and some really massive benefits as well. There's 3 major types of procedure. There's restrictive procedures where you just restrict the size of the stomach. That would be the sleeve or gastric banding, which are some of the super common techniques. This limits about 80% of the stomach, and there's a little bit less research around alcohol use disorder with the restrictive procedures, the gastric banding and the sleeve. That's starting to change. We're getting more studies, more research is being done now, but overall there's a little bit less data about that interaction. There's malabsorptive procedures, which remove 60 to 75% of the stomach. And there's combination procedures which combine both restriction and malabsorption. They restrict and eliminate parts of the digestive tract. This would be the Roux-en-Y procedure, which is really the gold standard for weight loss. Highly effective. It reduces the stomach capacity by 90 to 95%. Ton of research in Roux-en-Y because it is such a highly effective procedure, and worth knowing that that particular procedure may have as much as twice the risk of leading to post-operative alcohol use disorder. There's a study out there that had 11,000 something participants who had these different kinds of procedures, and the most effective weight loss procedure, Roux-en-Y, also had just about double the risk for leading to alcohol use disorder after the surgery. So that's the big picture. And again, just coming back to some of the benefits, going through these kinds of surgeries, people can lose, up to 47%, 60%, 70% of their excess weight. So if you think about what would 70% of excess weight means, it means that for somebody who is in a what we medically call the morbidly obese category, somebody who is extremely overweight and probably having a lot of negative health effects from that, they could lose approximately 70 pounds out of 100 of those extra pounds they're carrying. So that's a big difference. I don't know about you. I can just barely lift 70 pounds on a strong day at the gym. That's a lot of weight to be carrying around every day, and a real benefit of being able to shake some of it off. Now, about 50% of patients who have gastric banding end up regaining or not losing as much as they might have liked to. They might need to have the band removed. And, it's common with gastric bypass, particularly after the initial weight loss period that somebody might experience, they could regain as much as 10 to 15% of what they had lost, but they still might be really overall carrying a lower level of extra weight. And often that regain is viewed, we might see it as being a sign that that person hasn't had the support that they need to really change lifestyle habits, manage stress, manage environmental situations that would help them be more successful with that. So it's that weight regain, it's not necessary. It is possible to lose whatever percentage of the extra weight and keep it off, but it takes some effort and certainly the right kind of support. Some of the risks that are the non-alcohol risks and non-disordered eating risks of these surgeries would be nutritional deficiency, vitamins A, D, E, K, zinc. Those could all be deficient for people, some due to malabsorption. They're just not absorbing those nutrients as well. Some of it just because people are unable to consume as much of the foods that might provide those nutrients. Iron, calcium, vitamin B12, folate, those are all likely candidates for deficiency. And some people who are extremely obese before the surgery will be rocking up on the day of the surgery already in a state of nutrient deficiency, whether that's because of the particular diet they've been consuming or some of the impaired metabolism and impaired function of the digestive tract when the person is just that far on the extreme end. So they could already be nutritionally deficient before they even have the surgery that reduces stomach size and capacity for absorbing nutrients. Now, dehydration, death, those are other potential risk factors of either the surgery itself, but more likely complications if it's not well managed. These surgeries aren't undertaken lightly. Yeah, you need a real care team around you helping you navigate the impact of the surgery and be able to really thrive with it and get the best out of it and avoid some of the worst. One more side effect I want to talk about, because it relates to binge eating disorder, and identifying some disordered eating that some people might experience post-operation, post-op. And that's something called dumping syndrome, which it means that after some of these surgeries, particularly the Roux-en-Y, but it could be any of the surgeries, when you eat something that has, especially something that has a lot of fat or a lot of sugar or a lot of protein, you eat something, and essentially because of that reduced stomach capacity and reduced absorption, the food just sort of shoots right through. I could leave some of that to your imagination, what I mean there, but there's symptoms that you would get just like if you had really low blood sugar. Could be dizzy, could be lightheaded, could be sweating, could be nausea, could be real fatigue and lethargy. This would typically happen about half an hour after eating, but it could be as much as several hours after eating. Now, why this relates with considering where disordered eating could come into the picture is because with this dumping syndrome, you could also have what's called purging, the symptom of purging. That could be the vomiting particularly, and it could be everything coming out the other end. And this could be because of just the physiological effect of high fat, high sugar, high protein foods on the reduced digestive system, but it could also be because of a binge and purge kind of eating pattern of purposely inducing that purge, purposely inducing vomiting to try to continue weight loss, or out of a misguided idea about what would help support further weight loss. So the purging is incredibly dangerous. It can lead to electrolyte imbalance, heart arrhythmias. It can lead to new food intolerances that the person has not experienced before, because it impairs the connection between the stomach and the intestines, and food is not being digested properly. And certainly it needs to be really carefully assessed. Is this a mechanical and physiological thing that's happening, or is there that aspect of some disordered eating there that we could really maybe address? So with those risks in mind, we're going to look a little bit more closely at the psychological aspect of weight loss surgery, because bariatric surgery alone cannot be the only intervention for someone who needs to lose that significant amount of excess weight. Something got us to the point of having that much excess weight in the beginning. You know, we don't do the weight loss surgery, the bariatric surgery. You have to be at a certain body weight to qualify for it. It's not for people who are just a little overweight or a little bit chubby or would like to lose a couple pounds. Yeah, having surgery on your body is extreme. It's an extreme impact, and it's reserved for the cases where there's just a ton of extra weight to lose. And so we get there to that state of having that much to lose due to certain psychological vulnerabilities that lead to the problem. That could be a pre-existing history of binge eating. We'll talk about that more in a minute. It could be due to depression, anxiety, a feeling of lack of control in life, impulsivity, difficulty managing stress, food addiction and dependence upon food to manage our emotions and cope with pain. And so if that psychology isn't addressed, if those tender emotional vulnerabilities aren't addressed, then the odds that the surgery could be successful and really help that person come to that place of thriving physically and mentally and emotionally, that the odds of success are much lower. I'll share that there's quite a bit of research around the amount of childhood trauma faced by people who get to a point of extreme overweight. And one study of 368 patients showing up for bariatric surgery, looking at this study there, 66% of the women and 47% of the men had at least one significant childhood trauma. And the more traumas they had and the more intense or severe those early traumas might have been, that correlates not only with the fact that they are now carrying all of this extra weight, so understandable, I think, for many of us, that we might start to carry that extra weight almost in a protection mechanism. We've been really hurt in some way, and carrying that extra weight can give us that feeling of safety and security and insulation against the pains of the world. However, it comes with the side effects also of the health impacts and quality of life impacts of the extra weight. And it also comes along with, for the people who have the more severe childhood traumas or the more numerous earlier traumas, that's also going to correlate with higher risk of major depressive disorder, post-traumatic stress disorder, various anxiety disorders, alcohol use disorder, binge eating disorder. So in this study of 368 bariatric patients, again, 66% of the women, 47% of the men were showing up for surgery with this really complicated basket of factors already in place before going into the surgery. So this stuff has to be addressed if the surgery is going to be successful and help that person reach the goals that they're looking for in their life, to thrive, and in their recovery, to finally feel as good as they can. Yeah. When we look at eating disorders pre-surgery, there's a really, really concerning lack of identification of official diagnostic eating disorders and untreated eating disorders prior to bariatric surgery. And one of the impacts of that, particularly binge eating disorder, if that's not identified and addressed and treated prior to the weight loss surgery, that individual will have less weight loss after the surgery. So it's really to the benefit of the individual who perhaps is suffering with that kind of dysfunctional eating pattern, to be vigilant about identifying it and addressing it and getting the care and support that you need if you want to be successful with that weight loss and the weight loss surgery. And then post-surgery, those eating disorders also are likely to be underreported, misidentified, confused. Is the purging because of bulimia nervosa? Is it a bulimic kind of purging? Is it just a medical purging like we talked about? So a lot of confusion there, misidentification. At the lowest level estimate, 12% of post-bariatric surgery patients report self-vomiting to try to continue losing weight. So that's a low estimate, is that at least 12% of people are purging on purpose to try to lose weight. And one thing that I want to put out there before we move into talking about the interaction between these surgeries and alcohol particularly is this idea of something called symptom substitution theory. So this is it's a psychological theory that points to a dynamic. See if this sounds familiar for anyone. It's the elimination of one behavior without treating the underlying cause, which could then lead to a replacement behavior. So we might see that in the rooms a lot, yeah? Maybe I successfully eliminate my drinking or drug use behavior, but if I don't do the work, if I don't work the steps, if I don't have a counselor, if I don't do that inner work to address what got me there in the first place, too easy to swing over to just a substitute addiction. That's often sugar, often that's food, but could be other things as well. You know, gambling, pornography. We see a lot of substitute addictions happening when people put down their substances and get clean and sober. And that would be an exemplar of this symptom substitution theory. And so for people who are already grappling with substances and binge eating and mental health challenges, wow, we really want to be able to bring some light to that and bring some healing to that, to be able to be successful on all those fronts, and rather than jumping out of one frying pan and into the next fire. Yeah. And I think those of us on this call know recovery is possible. Some of us it's just a little bit more complicated for. Yeah? So now we're going to shift gears and look more specifically at the weight loss surgery as it impacts with binge eating disorder and bulimia, and then we'll look at the drugs and alcohol. So again, some of us may be very familiar with emotional eating, where we use food to cope with stress or traumatic events or uncomfortable feelings. We might experience that when we put down our drugs or alcohol, that could get even stronger for some of us. So if we look at the official diagnostic criteria for binge eating disorder, this means consuming large amounts of food in a limited time span with a real sense of loss of control over it. And there is a concerning phenomenon in which bariatric surgery patients may either have had the markers for binge eating disorder before the surgery that did not get identified, or even if they didn't, they could find that blooms later. Oftentimes, the most common picture we see with that is binge eating disorder before surgery, usually not identified, and then going through that weight loss surgery, and then afterwards finding that bulimia nervosa happens. So we transition from the binge eating disorder to the bulimia nervosa. And the difference is both of those feature the consuming really excess amounts of food, but the bulimia nervosa has that purposeful purging side, trying to get rid of it one way or the other. It's unknown why the binge eating disorder before surgery often shows up then as bulimia after the surgery, but as many as, depending on the study you look at, it's anywhere from 10% to 50%, 50% of pre-operative weight loss surgery patients might have binge eating disorder without having been diagnosed or treated, and then they have that risk of that flipping over to bulimia after the surgery. One study of 300 obese people, 66% of them, and it qualifying for weight loss surgery, 66% of them did have a history of an eating disorder. 48% of them probably had binge eating disorder. They met the criteria for binge eating disorder before the surgery. And of them, almost 29% developed bulimia after the surgery. So those are big numbers, and it goes to show that these surgeries are not a magic bullet. They don't fix all the problems. When we see that as many as 50% of people have that eating disorder to begin with, and a full quarter of them, it's going to potentially morph into a different kind of disordered eating afterwards. And it's hard to identify, in part because with these surgeries that have reduced the stomach capacity so much, what counts as a, quote, binge might look really different. For someone who has not had a bariatric surgery, a binge could be thousands and thousands and thousands of calories at a go, whereas for a, quote, normal eater, maybe you could easily eat a quote normal lunch that had, let's say, 800 calories in it. But then after a weight loss surgery, something like 600 calories could be a full-on binge, just because you might have a stomach capacity that's 90% smaller. So the amount that qualifies as a binge is different, and really needing sensitive and well-attuned care providers to help figure out, where am I sitting with how I'm eating after this surgery? Am I eating in a healthy, balanced way? Is it getting a little off balance in some direction? And how can I bring it back to be sure that I'm thriving and helping meet my goals here? And then, as a bridge to talking about the drugs and alcohol, the increased risk for alcohol use disorder after surgery, it's even higher in patients who binge eat. So when you get all of those factors coming together, not just the excess weight, not just the weight plus the surgery, but the weight plus the surgery plus the binge eating, that really skyrockets the risk of alcohol use disorder after the fact, after the surgery. So let's shift over there and talk about that for a minute. As I commented at the beginning, the gold standard weight loss surgery, Roux-en-Y, might have a worse risk here, but really all of the weight loss surgeries are clearly connected with an increased risk of alcohol and substance misuse. And up to a third of people who go through these bariatric surgeries, up to 1/3 of them will experience new drug and alcohol problems after the surgery. So this is not talking about people who already have that history of, let's say, alcoholism before surgery. These are people who have always been, quote, normies, normal drinkers or not drinkers or no drug problems. Going through that surgery, up to 1/3 of them will face new onset drug and alcohol problems. This is a huge number. This impacts every single one of us in these rooms, whether it's our personal story or the story of somebody talking up there at the front of the room and we don't even know all this is going on for them at the same time, or maybe it's the story of our friend or our sponsee or someone that we know. So really common story, and something I think we need to care about. Why is there the increased risk of drug and alcohol problems after the surgery? There's altered metabolism of alcohol. We've removed a lot of the stomach, or removed access to the stomach, which is the first place that alcohol gets metabolized after having that drink. So now most of the stomach is gone, and simply the metabolism of the alcohol changes. The reward pathways in our brain, our dopamine pathways, change. Alcohol becomes more rewarding in some regards. The same amount of alcohol creates a higher neurological sense of reward and reinforcement after the surgery because of some of those hormonal changes. There's increased sensitivity to drugs and alcohol, and potentially reduced sensitivity to some of the sedative effects of alcohol. So we see somebody who hasn't had the bariatric surgery and somebody who has had weight loss surgery. Let's pretend they're same gender, same age, same weight, right? All, as similar as possible. And they both have the same amount of alcohol. the one who has had the weight loss surgery is going to have a higher peak blood alcohol content, and it's going to take longer to clear out of their system than the person who hasn't had surgery. And additionally, the person who has had the surgery will feel some of the rewarding, feel-good impacts of the alcohol and drugs. They'll feel that more strongly, but they'll have less sensitivity to the sedative aspect of drinking. So we're really still pulling apart all of the mechanisms involved. It's incredibly complex and complicated, but there's a lot of reasons why there's this increased risk to alcohol and drug use post-surgery. And something, again, to think about, and that I perhaps is not spoken about as widely in the medical circles, is that with increased alcohol use or misuse, you get less weight loss as a result of the surgery. And that's why we are undergoing these surgeries in the first place, right? Nobody's doing that just for fun on a day off. There's a goal there. We want to see that weight loss, and yet that risk of alcohol misuse can reduce the odds of that weight loss being really successful. This overall picture, it applies to teens who undergo bariatric surgery, whilst their drinking patterns tend to continue looking similar to the drinking patterns of teens and young adults who did not undergo the surgery. They, again, from the same amount of alcohol, they get up to double the blood alcohol content. So there's something different happening with the metabolism there, and some of these groups are being really followed very closely in the research. Groups of teens who have had the surgery, which is newer than adults having the surgery, we're following those cohorts, those groups, because there's a real concern that because of the different way the body's metabolizing alcohol after that surgery, that this group might be at risk for more drug and alcohol problems down the line than they would have been otherwise. Women, looking at that younger picture, women who are younger than 26 years old, who have had weight loss surgery, they are more likely to have alcohol-related diagnoses after the surgery, problems with alcohol getting diagnosed and picked up in the medical setting. So that's definitely a risk factor we see for this, is younger weight loss surgery patients, males, smokers, people who drink regularly. Okay, no surprise there. If you drink more regularly, you're more likely to have a drinking problem. I'm sure that many of you in this audience are shocked to hear that. But again, it's all the more so with the bariatric surgery. If you've got a preoperative alcohol use disorder, whether it's like an untreated alcohol use disorder before the surgery, your odds of that really escalating out of any sense of control or manageability, that gets worse after the surgery. And one risk factor that I find really poignant is a lower sense of belonging. So people who don't have that same sense of connection and belonging, and maybe more isolation and abandonment and loneliness, are at higher risk of this disordered alcohol pattern to arise. And then we think back on those numbers we reviewed about how many people coming in for this surgery might have pre-existing traumas and significant, some real significant mental health diagnoses that could impact the sense of belonging. So a lot of tenderness there, and a lot of appreciation for these rooms, for the spaces we come together to support each other. And also personally, I'm feeling like we need to maybe have a little bit more of that around these particular challenges. Let's see. I want to leave some time for others to chime in. So let me just pick out a few more of the really key aspects I think we need to be aware of. One is to say that the increased risk of alcohol use definitely does carry over to increased risk of drug use as well, although overall numbers would be more so alcohol than drugs. The studies go back and forth between like we know the Roux-en-Y, gastric banding, is really high risk for alcohol, and the other procedures, studies fluctuate back and forth to whether they're equally as risky as the Roux-en-Y or just also risky, but maybe not quite as much so. But again, Roux-en-Y being the gold standard in the field, it's important for people who are making those decisions. Hey, I'm thinking about having weight loss surgery. This would be a risk factor that we would want to know about to make that fully informed consent about which direction to go, right? And in an interesting study of 7,200 people, so 7,200 individuals admitted to a substance abuse treatment facility, anywhere between 2 to 6% of them had a history of bariatric surgery, depending on some of the details of that study. But let's say 5% of them had that history, roughly. And the ones going into this detox facility, the people who had the history of weight loss surgery were more likely to experience more severe alcohol withdrawal. And they also had been consuming significantly greater maximum numbers of drinks per day as compared to the people who hadn't had the surgery. So we really see that there's a real tight link there. And that link goes on long after the surgery as well. One study looked at people up to 12 years post-surgery, and they looked at both alcohol use disorder and binge eating disorder before, shortly after, and 12 years after the surgery. And what they found was that alcohol abuse occurred in 1 out of 46 patients before surgery. So alcohol use disorder, 1 out of 46 patients, which is, I'm so bad with numbers. I don't know what that percentage is. That's like less than 1%, right? And it was found in 22% after surgery. So big blossoming in the alcohol abuse. Binge eating disorder was present for 52% of the patients before surgery, and by 12 years post-surgery, eating behaviors that met the criteria for binge eating disorder were present in 39% of people. So it's a big number. That binge eating disorder hadn't been shifting yet. 12 years after surgery, the presence of both binge eating disorder and alcohol abuse both impacted on each other and raised risks of both. So I see this with the clients I work with. I'm thinking of one 60-year-old woman I worked with. She had 30 years post-bariatric surgery. She had been in and out of the rooms for alcohol recovery for many years. At the point I worked with her, she had maybe a handful of years sober. And yet still, with all of that behind her, she still really struggled to have a healthy, balanced approach to food, cravings. She had a lot of fear around food and her health. Her goals were some weight loss. She'd experienced some of that weight regain we talk about post-surgery. She wanted more energy left over at the end of the day to be able to have a little bit of fun. She wanted to sleep well and have a more stable mood. And yet she continued to be challenged by this relationship between food and her mental health and disordered eating and alcohol and recovery, and doing some really focused and committed work in all of those arenas. It has to be a holistic approach. And she ended up coming to a point of feeling that with all the work we did together, and then with a daily connection with her higher power particularly, really expressing some great moments of feeling like she was back in her body in a way that felt good, and she could feel at ease and have some trust in her experience. So we definitely see that having a holistic, multidisciplinary approach that's going to include appropriate medical follow-up, nutrition counseling, therapy, ongoing screening for disordered eating and alcohol misuse, and appropriate treatment then, that holistic care basket. And then for many of us, the tools that we use in the rooms and in our recovery programs and our 12-step programs and our refuge programs, we need that whole basket to be able to get the most benefit from from these procedures and to be able to thrive and feel great. We need to address the root causes of our depression and anxiety and really heal that trauma, come to turn toward ourselves and our experience with a sense of real self-compassion, finding connection with safe and caring others. Directly addressing lifestyle challenges, really needing to come up with what is a meal plan that works for me, whether it's a very structured meal plan, whether it's more of an intuitive eating based on balanced eating principles, mindful eating, hugely successful addressing binge eating disorder particularly. And I would just say we need to create spaces for people to have these conversations, to talk about and normalize all of these interrelated concerns, because too many people that I talk to are struggling with this complex knot of challenges and feeling like they are alone with it. And really, you're not. If that's your challenge, I promise you, you are not alone with it. So I think that's all for me. I'm going to leave a few minutes for the questions. I know it was a ton of information. And as I said, I will have this recording available eventually on my Facebook, so Gut Feeling Nutrition Therapy, and you can email me, lulu@gutfeelingcoaching.com, if you have questions or personal query, or just want the information about where to access the slides or when the video would go up to review. Information about one-on-one consultations, just pop me a note, lulu@gutfeelingcoaching.com. I'll be on again next weekend for the In the Rooms Summit on the 16th of May. We've got some great speakers popping into the rooms on sex and love and cravings. That's me talking about using food to bring those cravings down and stay nice and balanced in our recovery. Next week, I think we'll talk about perimenopause and menopause, and then we might go into talking about food addiction and binge eating disorder after that. But for all of you midlife ladies, we're going to talk about the health and physical and emotional health challenges around menopause next time. So I hope to really see you there. I'll also hang on for a few minutes if you want to pop me some notes.